Good afternoon, and welcome to Bridges at Lakeview Health, our educational series that connects addiction and recovery subjects to our communities across the nation. We want to thank you all for joining us for this special event. Today, we will be presenting on the importance of identifying co-occurring disorders and the treatment for successful recovery. For those of you unfamiliar with Lakeview Health, we are an adult-only addiction treatment facility located in Jacksonville, Florida. Since 2001, we have been leading the way in how addiction is perceived and treated and how recovery is managed. We are a passionate team of difference makers whose mission is to empower profound recovery through exceptional, dynamic, and evidence-based care for all individuals and their families. Our commitment to our patients does not end at discharge, but is continued through our aftercare and alumni support. Before we get started, I wanted to share a few housekeeping items. Throughout the presentation, participants will have the ability to submit questions via the Q&A section to the right of your screen. At the end of the presentation, the presenters will answer any questions you have. The chat box is for conversations between participants. You are all muted throughout this presentation and can communicate with each other via the chat. Please do not ask questions for the presenter via the chat box. Within 24 hours following the event, we will email participants the evaluation, survey information, and the event recording. As a reminder, to receive the certificate for continuing education credits, you must be in attendance for the entire presentation, complete the event evaluation, and pass the post-test with at least a 70%. Our presenters today are Lakeview Health's Chief Medical Officer, Lantie Jorandby, and Medical Physician, Kevin Holbert. Dr. Jorandby graduated with honors from Vanderbilt University with a Bachelor of Science in Neuroscience. She attended medical school and completed her residency at the University of Florida. For 7 years, Dr. Jorandby worked as a staff psychiatrist and mental health supervisor at the Veterans Affairs Outpatient Clinic in Viera, Florida. After completing her addiction psychiatry fellowship at Yale University, Dr. Jorandby became medical director for the dual diagnosis unit at McLean Hospital in Belmont, Massachusetts. She also served as faculty at Harvard Medical School in the Department of Psychiatry. After relocating to Washington, D.C., Dr. Jorandby worked as the chief psychiatrist of the Mental and Physical Health Clinic, where she held the position for 4 years before joining Lakeview Health. Dr. Jorandby is one of less than 200 physicians in the United States who is dual board certified in addiction medicine and psychiatry and neurology. Dr. Holbert has worked with Lakeview Health for over 6 years and has previously held positions as Associate Medical Director and Medical Director. Dr. Holbert has been treating substance use disorders for 20 years. He completed his medical school, general psychiatry residence, and child-adolescent psychiatry fellowship at West Virginia University. He continued his education and training through an addiction medicine and psychiatry fellowship, forensic psychiatry fellowship, and a geriatric psychiatry fellowship at the University of Florida, as well as the completion of family medicine residency at Piedmont Columbus Regional Medical Center in Georgia. Dr. Holbert's specialty interests include mood disorders, psychotic disorders, co-occurring disorders, screening and prevention, and overall health maintenance. In line with the Lakeview Health model, Dr. Holbert believes in treating the whole person. He uses a biopsychosocial approach with recognizing and treating general medicine, psychiatric, psychosocial, and addictive disorders together. Thank you for your time. Now over to our presenters.
Mic is on. Welcome, everybody. Good afternoon.
Thank you for joining us.
Really great to have you here with us.
Sorry for a slight delay, but we're ready to get rolling now talking about co-occurring disorders today.
We have a lot of information to cover, and hopefully we'll be able to get through everything. Bear with us. So we'll go ahead and get started. It's a great topic.
And you all will have access to the slides, even if we don't make it through all of them or all of them in as much detail as we'd like.
Exactly.
All right, so we're going to start out with a few questions to get you contemplating here. What is a co-occurring disorder? What does that mean? What are some common co-occurring disorders? And give 3 examples of treatment for co-occurring disorders. So hopefully we'll help respond to these questions as we go through the material.
Just a review of our objectives. We're going to talk about the neuroscience of addiction.
Briefly,
exactly. We're going to define what a co-occurring disorder is. We'll go through the epidemiology of co-occurring disorders and clarify what are some of the key co-occurring disorders that you will encounter. We'll talk about special populations, including how COVID has affected this population. And then finally, we'll talk about emerging and new treatments that are out there.
So this is a brain cut slide that probably several of you will recognize, have seen before. I just want to highlight some of the areas involved in the reward pathway, the dopamine pathway, including the VTA, ventral tegmental area, nucleus accumbens, the frontal and prefrontal cortex. And the slide tells you about the functions of dopamine, its role in motivation, pleasure, euphoria, and motor function, compulsive behaviors, perseveration. Just mainly want to highlight that this is a deep pathway that has been involved with survival drives forever. And this pathway gets hijacked in addiction and essentially sidelines the prefrontal cortex, or the senior governor of behavior, and can lead to compulsive, repetitive use of things that are irrational, even people realizing that they're making a poor decision. This pathway is activated by the release of dopamine, and that is one thing that addictive substances and behaviors have in common. They affect this dopamine signaling pathway. They activate it like nothing else has before.
Exactly. If we kind of take a look at this funny little slide here, you hit on it earlier about the prefrontal cortex. The prefrontal cortex is the governor or the CEO of the brain. It helps with making good decisions, making good judgments, rational thought. And when you take that part of the brain offline, as you can with addiction, there comes the insanity of addiction that we often see. People are doing things that don't make sense, that clearly are self-destructive, but they simply can't stop themselves. And so as you can see with this slide, these ladies are engaging in some irrational behaviors that logically they know are not healthy for them. But that prefrontal cortex is just not working the way it needs to work. And again, that's because, like you had mentioned, Dr. Holbert, there's a hijacking or hostage situation that's taking over the brain. And all these processes, all these circuits are being rewired and taken offline.
Yeah, so as patients typically say, I knew it was not a good idea, but I did it anyway.
Exactly.
All right, so this slide really focuses in on a nerve connection or synapse and gives you an illustration of how one substance, cocaine, affects dopamine transmission by blocking the dopamine transmitter in the transmitting neuron, which means it leaves more dopamine available in the synapse to transition over to the receiving neuron. And if you imagine this going on throughout the neural circuitry, it enhances all of those dopamine pathways. These substances light up these reward pathways like nothing has before. And over time, we think that the dopamine gets depleted to the point that without a strong stimulator like cocaine or other substances, people can't even feel good.
Right.
With day-to-day normal life.
Like eating a good meal or spending time with loved ones. Those are the things that are supposed to create good reward. And you lose that when someone is in an addiction like that.
Yep.
Another thing to highlight with addiction and neuroscience of addiction is the anterior cingulate and the compulsivity and the impulsivity that we see with addiction. As you can see, this little schematic says this person is saying, I just got to buy this, and the book is on how to stop impulsive buying. So again, it really kind of magnifies the idea that addiction isn't just that impulsivity. We're also seeing a compulsive nature, and I think
it reminds me of the 3 or 4 C's in addiction. Of course, compulsive use, which you just mentioned, Dr. Jorandby, use despite consequences, cravings, and loss of control. So we hear about that a lot as describing the pattern of addiction.
And again, I referred to this earlier, the anterior cingulate, the prefrontal cortex, the limbic system. That anterior cingulate is really part of the brain that's driving the compulsivity. But it's also connected to your limbic system and to the prefrontal cortex. Again, this isn't meant to be a busy slide, but it's just we're trying to explain and highlight that there's a very complex circuitry involved with addiction and mental health. And if you take one of these and take them offline or hyperactivate them, you get this impulsive, compulsive view of addiction.
Which brings us to our first star of the day.
Yeah, I love this show. It's one of my favorites. Monk is an obsessive compulsive detective. It's a great show, but it focuses on the obsessive compulsive disorder, which is more of an anxiety disorder. I think it also highlights, again, we're talking about mental health and addiction. Addiction has both features, that compulsiveness, and that impulsiveness that you can see sometimes, and really just, again, that neurocircuitry that's so complex.
And commonly involved with addictive substances, addictive behaviors, and various psychiatric disorders.
Exactly. Another favorite movie of mine, Inside Out. It's by Pixar. Little plug.
A little plug for the movie here.
But this is a movie about the different emotions in somebody's brain, and each emotion has a character. So this is the depressed or sadness character. She's blue. She's looking down at the ground, got a sad face. And I chose this because I just really wanted us to talk about the limbic system as well, and highlight that the limbic system is part of what we see with co-occurring disorders. Mm-hmm. It gets activated in that neurocircuitry again. When people are using drugs, they're using alcohol, they're often trying to maybe self-medicate a little bit. And if they self-medicate with alcohol, it might enhance or worsen those limbic problems. It's just a very kind of closed loop. I think you use that term.
Yeah, and you'll hear about the amygdala involvement of emotional memory, and it is remembering these experiences with substance use and other forms of addiction as a very pleasurable experience, and will lead you impulsively back to those behaviors again, as it kind of closes that circuit off and sidelines the prefrontal cortex.
Just takes it offline.
All right, this next slide shows again an illustration of the reward pathway, and it questions, does the brain reward threshold change with drug use? Yeah, it does. And does it change back? Well, yes, but it can take a good bit of time, and it varies from one substance to another or a combination of substances. But yes, with treatment, sobriety, overall good health, we do see a trend to return to a more normal state.
We do.
But it takes time.
And we're going to highlight a little bit of what treatments are available to really re-engage the brain and heal that brain when people are in recovery.
This slide just, the images just highlight with cocaine, progressive cocaine use, alcohol use, food addiction, how over time there is a reduction in dopamine receptor availability, or again, strengthening the thought about dopamine depletion over time with continued addictive behaviors and drug use.
Exactly, and you can see it's not just a chemical effect. People that have a food addiction also show those changes in the dopamine receptors.
All right, so this may address the first question we offered today. What does co-occurring mean? You hear this a lot in these settings.
Yes.
We refer to co-occurring meaning the existence of a primary psychiatric disorder along with a substance use disorder. Old term was dual diagnosis. Now you may hear co-occurring referring to co-occurring psychiatric disorders, medical conditions, which our approach is to look at all of that and address all of that here the best we can.
But for our purposes today, it's targeting that psychiatric and substance use.
Right, and that might be a key for the post-test.
Yes. Wink, wink.
There's a couple of stats on there from SAMHSA's 2014 to 2012 National Survey on Drug Use and Health. 25.5 million adults in the U.S. with substance use disorder, 8.4 million also have a co-occurring psychiatric disorder.
And that's also an important number for our post-test.
Yeah. All right, so why do we talk about this stuff? Well, so that we can hopefully better help each other get to the optimal approach for assessing, sorting these disorders out, and applying the best treatment for the success and well-being of our patients. So as this first point is, challenges for providers to differentiate between primary psych disorders, major depressive disorder, GAD, bipolar disorder, or are they symptoms caused by substance use, or is it a combination? And that way it'll help you figure out how to apply the best treatment for them. And of course, we've seen this before, symptoms of coexisting psych disorders may be interpreted as poor recovery from substance use or something. If they have poor recovery, we need to look further and see what's going on. Have we missed something?
Exactly. That's really a key piece. Is if you're not getting the outcome you're looking for, what else is out there that you haven't uncovered?
Absolutely.
So some common psychiatric disorders that go hand in hand with substance use include affective disorders like depression or bipolar, anxiety disorders, psychotic disorders, personality disorders, post-traumatic stress. So you can see this is a very long list. It includes eating disorders and ADHD, organic or neurologic disorders, as well as substance-induced mental disorders, which we'll go into in a moment. But again, a very long list. May not be completely comprehensive because there are many things out there that are common.
It just illustrates that there's a lot to consider in your differential and a lot of things to assess for and look for.
Absolutely.
All right, so this next slide talks about relationship between SUD, substance use disorders, and psychiatric symptoms. Well, it's complex, and one can affect the other, and one can look like the other, basically. And comorbidity should be the expectation, not the exception. I think in our population, what do you think about co-occurring disorders excluding medical?
Well, that is a great point. I mean, I'd say at least 75% or more.
Yeah, I'm thinking most of the time it runs at the minimum 50, but more like 3/4 or 75% in our residential population. So how do we figure it out? Well, it requires a comprehensive assessment to determine all possible or a working diagnosis to start with, multiple resources, your interview, your H&P, your labs, your previous records, your collateral data. Apply all of that to try to come up with the best conclusion. And what do I mean by a longitudinal timeline evaluation? I tend to ask patients to give me some examples of how they were doing if they had some periods of sustained sobriety in the past. And if they are depressed now, but tell me, hey, after I was abstinent for a few weeks, I didn't need any medication and I was fine. You know, this is likely to be more substance induced. But if they have good periods of sobriety and they feel as miserable in between times, then we maybe are likely looking at something else. So you come up with a flexible diagnosis, and then as more information comes in as we go forward, you adjust that and adjust the treatment accordingly.
Right. You love that working diagnosis,
I like that.
which I think is very applicable.
Yep.
So just thinking about multiple addictive substances that could contribute to substance-induced mental disorders. As you can see, there's a variety listed here, ranging from a very common one, which is alcohol, sedatives. We definitely have to think about opioids, especially in this day and age. Opioids are very common and everywhere. Less commonly, I know you and I have seen are bath salts and synthetic cannabinoids like
I haven't had a spice case for a while.
Or K2, exactly. One of the things that we have seen a spike on is methamphetamine-induced psychosis, which is a really tough thing to see and can be prolonged even past detox.
Absolutely. So you see the substances there, the usual players. I think we see the alcohol still pretty consistently. Don't see much PCP or really a lot of hallucinogens. Intermittent use in patient histories typically. Inhalants intermittent, but definitely mainstays alcohol, cannabis, opioids, sedative hypnotics, and we've even been seeing some more cases of sedative hypnotic withdrawal delirium.
Withdrawal delirium, which is also more, I think, even since the pandemic started. I suspect more people are going towards that for anxiety and sleep issues. The DSM-5, which is our latest diagnostic and statistical manual revision, actually requires that there be about 1 month of development of symptoms from the time of intoxication and withdrawal, and that these disorders are not common. They are common, but they're usually short-lived. And so if you have that month of abstinence and you're still seeing these symptoms of anxiety or mood or psychosis, you have to kind of consider if there's a more independent diagnosis going on there for mental health.
And of course, you do that, the diagnosis is likely going to change. Exactly. It commonly does as we follow these in time.
Yes.
All right. So this next slide just, again, lists the substance-induced mental disorders that are included in DSM-5. There are several. Depression, there are other mood disorders, bipolar, anxiety, OCD, psychosis, there are cognitive issues.
Long list.
We've been seeing some more of that in neurocognitive issues lately with prolonged use. Hallucinogen, persisting perceptual disorders, and symptoms of intoxication, withdrawal, sexual dysfunction, and sleep disorders. Mm-hmm. And I think everybody I see during the day has some issue with sleep, particularly in early recovery, as well as the anxiety you mentioned earlier.
Yeah.
That's two of the more common things that I'm addressing during detox and beyond.
Yeah, sleep is tremendously challenging. And I think what I see is it changes over the course of the time people have in sobriety. Yeah. The longer they are in sobriety, the sleep improves. But that early piece where we're seeing a lot of our patients, it's a big struggle.
Right, and I'll have people that want their sleep to be normal within a week.
Right.
And they can't understand why they still need to be on some sleep aids at times. And it's a good goal to be completely abstinent if you don't need medication to be off of it. But sometimes we have to educate that this is going to take a little bit of time because it took time to get into this effect.
And sleep is so important. It's when the brain repairs. It's when the brain rewires. And so getting really good quality sleep is one of our priorities.
And I'll mention that also in sleep disorders, I've had several patients lately that we've been referring for sleep studies afterwards. Yes. For possible sleep apnea, and they had no idea that this, might have been playing a big part in their mood, their blood pressure issues, their attention and concentration. All of that might be improved if sleep apnea is identified and treated.
How long do you wait after they're out of treatment to refer them to a sleep study?
If there are normal length of treatment,
like 4 to 6 weeks,
several weeks, then I'll just try to get them in with a sleep expert as soon as we can afterwards.
No, I think that's an excellent, and highlights again the whole complex nature, medical, biological, psychological.
And keeping all of it in mind.
Exactly, keeping it all at the front of your mind. So I can take this one. Post-traumatic stress disorder. This is another fairly common co-occurring disorder that we see in our population. And epidemiologic studies actually show that about 50% of veterans diagnosed with PTSD also have a substance use disorder. And if you follow that over, we'll talk a little bit more about that. We also see bipolar disorder is a very common co-occurring disorder. About 42% that have alcohol use disorder, and 20% of those have a cannabis use disorder. So very high association there with those two mood issues.
And I have a lot of people that I do treat and have treated with bipolar that feel a little bit better, or they don't feel as up as they used to on their medication. Right. And a patient comes to mind right now we've had in several times that decided he didn't need his mood stabilizers anymore. And then he became more dysregulated, more impulsive, started using more, and then all of it tends to just crash together. But yeah, you see the significance of bipolar disorder and recognition of it and maintaining treatment. And that's a point to maintain treatment, good treatment for any of these primary psychiatric disorders along with the addictive disorder. That's the only way they're going to stay on track.
That stay in sobriety and recovery.
Yep.
So looking also at the psychiatric research interview for substance and mental health disorders, or PRISM-4, one study found that those with comorbid substance and psychiatric disorders, 41% had a psychiatric disorder that was independent, 7% had a substance-induced mental disorder, and then 38% had both. So as you can see, those are pretty significant numbers and really, again, highlighting the complexity of this population.
And the need to recognize it and identify it.
Exactly.
And so of those statistics, you would expect the 7% in there to improve.
Yes, you
after
would.
the month or so, and without the specific treatment for a primary psych disorder.
Exactly.
As long as they were sober. Okay, this slide just highlights the increased prevalence of substance use disorders in folks with mood or anxiety disorders. The first few columns there refer to any drug out there. The very first column refers to all respondents, and then if you add in a mood disorder or an anxiety disorder, you can see how the prevalence of drug abuse and dependence will rise. It first is illustrated with any drug, and then specifically the opioids, amphetamines, cocaine, and cannabis.
And it really tracks, as you can see, really closely. This is just fun. It's Elmo.
That sums it up nicely.
It's just very important to think this is the rule rather than the exception. You have to start looking or you won't find it. And it's just a very high prevalence.
So again, assess and access.
I like that.
Comprehensive assessment, identification of the problems, disorders, and then facilitating access for these patients to the appropriate treatment ongoing.
Yes,
and not just the
maintaining
inpatient, not just residential situation. That's where our aftercare team comes in play, keeping the appropriate treatment going for these folks wherever they're going after discharge.
Right, at that aftercare, understanding that this is a lifelong illness most of the time. You're looking at a chronic illness that really needs to be maintained and managed.
Definition of addiction, chronic relapsing brain disease.
Exactly.
Okay, so occasionally some of you may have run into some issues obtaining the best history from a patient, maybe a little worse than on the first presentation if somebody's still intoxicated or going into withdrawal. Cognitive problems, example may be alcoholic dementia. How about thought derangements? Maybe a schizophrenic who's been off his or her medications for a while and experiencing psychosis. Emotional pain, trauma is very common in our population.
We see that commonly. Yeah.
Physical pain, some people have had injuries, medical procedures, started on opiates, and that was the pathway. In a vulnerable person, that was the pathway to their addictive addiction and situation now. Personality characterological problems, you might run into somebody with antisocial personality who's a little bit resistant to cooperate. And denial, sometimes in these circles, we talk about denial as an acronym, even though it's the wrong use of the letter N, as meaning don't even know I am lying. So I'll have lots of people tell me maybe on the first presentation of interviews, this is pointless, I don't need to be here. Those folks maybe have been compelled to come in from a family intervention or legal, maybe they got their third DUI, their lawyer said this is the best thing for you to do, but I still don't think I have a problem.
Exactly. It's very powerful, unfortunately. So one of the things that we really believe in here at Lakeview is doing psychometric testing. It's really imperative for us. And by no means are these psychometric tests and the results the final decision on what someone might have, but it does guide treatment. We use it frequently. We'll even retest as people go through treatment. So they start out with, as you can see, one of the tests we do is a major depressive disorder test called the PHQ-9. We'll see a very high score initially at admission, and then as they progress through treatment with us over 4 to 6 weeks, that score will go down, and that's very gratifying to see. The others that we use are the MDQ for bipolar disorder, the GAD-7 for the generalized anxiety disorder category, PGI for treatment response. And, I think these are very, very good utility for this population.
Right. If you've got a high MDQ score and your interview history, is uncertain about a mood disorder or bipolar disorder, it suggests you need to explore a little bit further. But again, a positive on these, especially early on presentation, it does not equate to an automatic diagnosis. It's just the additional tools that we employ.
Exactly. And just informs how you want to move through care. Some of the hypotheses out there for substance use and co-occurring disorders are by a variety of different docs. So one of the more popular ones, well, it falls in and out of favor over time, but it is one of the older theories, is by Dr. Edward Consian. And he called this the self-medication hypothesis. And he even broke down the types of substances people might use if they have, for instance, anxiety. People who have anxiety, according to his theory, gravitate towards alcohol or benzodiazepines, whereas people with depression might gravitate towards amphetamines and cocaine, things like that. Again, this hypothesis is commonly accepted and then disregarded, but it is prominent and it is something that often our patients talk about themselves.
Yeah, I do have several patients that, going back to how their addiction started, will tell me a friend or a family member offered them medication, maybe a Xanax for their panic disorder, or maybe a drink of alcohol for their social anxiety.
Right.
And then in susceptible individuals, that can be the start of the problem.
It's off and running.
Yeah, as they gain insight and as I talk with them about this, they learn that was a trap, and then that over time, continued use of those substances actually aggravates and worsens the problem that they thought they were treating.
Or their mood issues, exactly. Yeah. And again, I think that goes back to the dopamine depletion theory that we talked about earlier.
So this slide, you see Dr. Gold's name up there, one of our great mentors, referring to the neurotoxicity of addiction. You probably remember this, well, some of you. I remember it from the Nancy Reagan era of just say no, but it was really just illustrating that addiction does affect the integrity of neurocircuitry, the structure and function of the brain, and it's not something that reverses after a couple of days of detox.
Exactly, and I think that Dr. Gold's theory, and he draws from Dr. Volkow and NIDA, is that this circuitry is definitely dysregulated, it's altered, and it takes some time to rewire and heal. And I honestly believe that where we are going now, and I'll show you a kind of a busy schematic.
Complex.
Yeah, very complex. And if you take a look at this particular slide, it really draws from both of those theories. It draws from the Consian theory and from Dr. Gold and NIDA's theory of the fact that there is circuitry that's altered, the brain disease piece of this, but also that there's emotional, negative emotionality involved with addiction as well, because people, you think about the self-medication theory and how people are trying to improve their mood or their anxiety levels. So that's what this busy slide is just trying to explain or illustrate, is that there's a very complex dynamic going on here. And that negative emotionality really plays an important role. Again, thinking about what you'll see at the end of this presentation in the post-test.
Keep negative emotionality in mind. And if we were looking at that progress, you would see executive functioning being sidelined more. And again, I think it just illustrates the multifactorial nature of this. All right, co-occurring mood and substance use disorders. So now we're going to talk a little bit about some of the different primary psych disorders and their relationship to substance use disorders. So in general, over 10% of the population has experienced some depressive disorder at some point in their lifetime. And in our treatment settings, major depression is the most common co-occurring psychiatric disorder. Lifetime prevalence rates have a range there, depending on the treatment setting, but it's pretty significant, ranging from 15 to 50%. And this is going to be a common message that primary psychiatric disorder tends to aggravate the success of abstinence and substance use disorder, and vice versa. So here it says major depression with SUD is correlated with worse outcome, worse symptoms, heightened suicide risk. We'll talk about suicide a little bit later on,
that.
so that's a very important thing to keep in mind and keep reassessing for. So a comprehensive treatment, this mentions pharmacotherapy, cognitive behavioral therapies. There are other therapies, effective therapies that help with depression and need to be applied in these situations.
So one of the things we also see when we think about co-occurring mood disorders is bipolar disorder. And bipolar disorder is actually less common in people seeking treatment for substance than major depression. However, there's a very strong association with bipolar disorder and someone who has a substance abuse disorder. And in fact, having a bipolar disorder actually increases your risk of developing or having a substance use disorder by about a factor of 4.
Pretty significant.
That is significant. And then co-occurrence associated with worse prognosis and poor treatment outcome, again, just really illustrating that somebody who has a bipolar illness or a mood disorder, their likelihood of staying in good recovery is much worse if you do not address those issues.
Right. Addiction does not occur in a vacuum.
Yeah, exactly.
All right. So we can't just, somebody we may recognize has an addictive disorder, but you've got to do the comprehensive approach to improve their chances at success. So in general, as this points out, mood symptoms are common as a result of various substances, either during the intoxication phase, withdrawal phase, or chronic use. And it's important to distinguish the symptoms, these secondary symptoms, from a primary mood disorder, again. And generally initiating treatment for the substance use disorder and striving to achieve abstinence should be a first step in treating co-occurring mood and substance use disorder. Help clear the water. It's less money. Help sort this out. So again, as I had mentioned earlier, you examine the history, the course of the mood symptoms. Does it tend to be aggravated or exacerbated only when somebody is using or shortly thereafter? And the last point is that these independent depressive and other mood disorders respond to the same treatments generally that work for these mood disorders in folks that don't have substance use disorder.
They do.
Oh, another star.
Another star. Elmo and now Bruce Springsteen. So Bruce Springsteen, I chose to highlight him. He actually had come out in the last probably 10, 12 years and revealed that he'd been treated for depression and substance use disorder for 25 years with a psychiatrist and with a therapist. He has a strong family history of this in both substance and mental health, and And so he really credits his treatment team with his success as far as finding good quality of life and healthy recovery. And I like this because it highlights too that fame and fortune, financial success and career success do not insulate someone from a substance use.
They don't give you a pass.
Exactly.
From the possibility of having these psychiatric disorders and substance use disorders.
Yeah.
Again, it doesn't discriminate. And I'm glad people of prominence
are coming and
speaking out about this.
Really helps to dispel stigmas that are still out there for both of these conditions.
Okay, so we have a couple of exit ramp options here that some people may present with. I have lots of people that tell me, when I'm clean and sober, I have all I need in life. I have a family. I don't have financial troubles. I don't have legal troubles. I feel depressed, but I have no reason that I can think of. But perhaps they'll have a family history. They're more neurochemical or biological-based depression. And then from the damages of addiction, we have a lot of people presenting with good reasons for depression, from loss of relationships, traumas, medical problems, financial and legal. So really, you just sort all of this out if it's a primary depressive disorder, whether it's for the no good reason or a good reason, apply the effective treatments.
Talking about co-occurring anxiety and substance use disorders, this is a population that we see commonly here. We hit on it earlier. If you look at, for instance, a primary care population, 20% of people in a primary care setting actually have some form of an anxiety disorder, whether it's generalized anxiety, panic, or social anxiety. And if someone has a diagnosis of anxiety disorder, that actually increases their risk of a substance use disorder or precedes it by about 80%. So that's a huge number. Yeah, and there's a lot of symptom overlap. Again, really important to get that longitudinal history and explore and investigate that working diagnosis.
And it's a challenge when these guys, these patients present with a long history of anxiety that they've either self-treated, and some of them have been prescribed benzodiazepines,
Right.
various benzos.
Yes.
And it's a challenging time in the first few weeks of treatment when somebody's underlying anxiety disorder is there, along with the benzo
detox.
withdrawal.
Right.
Anxiety, the exacerbation of that. And some people, it really takes a lot of support, encouragement, and therapies to treat them
really
and get them through that and to succeed. It's really difficult.
Yeah. That is, anxiety disorders are a huge challenge.
Yep.
You definitely see that. And there tends to be a relationship with alcohol and anxiety, benzodiazepines and anxiety. There's a lifetime prevalence of anxiety disorders doubled in individuals with opiate use disorder. So all of these things are pretty important to really consider.
And this last point about cannabis use,
Yeah.
I have so many people say, I have the medical marijuana card for my mood, for my anxiety, for my pain.
Medical marijuana is legal here in Florida and many other states.
And a lot of them found it effective for all of those things when they first started smoking or using it in other forms. But usually, as they gain insight, they see that has really led to an increase in their anxiety. They are less involved in things. Instead of involving themselves in things that cause anxiety, they smoke and avoid, and that, of course, increases their avoidance and anxiety. So, aggravated cycle.
So thinking about psychotic disorders.
Oh, yeah. So again, we list some of the common players, substances that can cause psychotic disorders: alcohol, cocaine, cannabis. I've seen more cannabis-related psychosis lately.
And I think it goes to the percentage of THC that's now in these products.
Much more concentrated, and in some cases raising the question, is it a cannabis-induced psychosis that's going to resolve? Was this person prone to develop a psychotic illness such as schizophrenia, and it was brought in earlier by heavy cannabis use? I have a couple of cases recently.
Yes, and they tend to be younger, like early 20s males who possibly started vaping when they were in their teens. There's some interesting genetic research showing that there's genes that can be triggered to flip on when someone uses marijuana in that particularly developmental brain phase. So we've had a number of cases of late where it's a little hard to tell if this is an actual substance-induced mental disorder or if it's going to blossom into an independent psychotic disorder like schizophrenia.
And of course, I've dealt with lots of families and significant others recently who really want it to be something that's going to be temporary, and think of other causes such as a cannabis withdrawal or abnormal minerals in the body or and things like that, and organic medical issues. And then out of that list, the amphetamines, really seeing more methamphetamine-induced psychosis. And I have one patient in mind that's been a repeater that required antipsychotic treatment and even one inpatient psychiatric crisis stabilization, brief admission before he came back to treatment, medications such as Geodon and Zyprexa. And actually this last time he had some persisting paranoia, and he actually discharged on his Zyprexa. He's doing okay now, but I'm really telling these patients that are using amphetamines, and some of them, it compels them to be more serious about their sobriety, is that they said, "Oh yeah, I was really tripping the other night. I thought I was this person or somebody else, and walked into somebody else's house, things like that." And I tell them, you might not come back from that, at least completely. So sometimes that kind of shakes them a little bit, being more serious about it, compliant. Yeah. So middle point on here: if these symptoms are psychosis persisting more than a month after cessation, think about another primary psychiatric disorder. And less than 15% of patients with substance-induced psychosis will have psychotic symptoms after that month. And then the exception is the meth-induced psychosis. Okay. Up to half of individuals with schizophrenia have a lifetime history of substance use disorder, and that's excluding tobacco and nicotine, which known to be highly associated.
Exactly.
And we just mentioned there's some data that suggests use of drugs or alcohol can lead to earlier onset of schizophrenia. Of course, nicotine, tobacco use disorders are very common, and as I tell everyone, anytime's a good time to quit smoking. We could go into a whole separate talk about the problems, medical issues with continued tobacco use. Again, it points out the comprehensive assessment is needed and evaluate for general medical conditions, intoxication, withdrawal, delirium, dementia. And of course, it mentions mood disorders such as major depression with psychosis or bipolar with psychotic features. Okay.
And I think you hit on this earlier. It's just the goal is really to try and integrate treatment, determine what is a primary disorder versus a substance-induced, getting people to really engage in treatment and, like you said, be serious about their sobriety. These are all going to be very important so they can have really good outcomes and remain really high challenges.
Absolutely.
Just to talk a little bit about attention deficit disorder and substance use, and we see a high number of people that come in for treatment here.
That believe they have attention deficit hyperactivity.
And I think you have brought up a very good point that to really have a true diagnosis of ADHD, someone must have had symptoms prior to age 12.
Yeah,
exactly.
Yeah, we'll see that on the next slide, actually.
Yes. But as you can see here, there's in adults with ADHD, the rate of substance use is 15%. And ADHD, just as a definition, is the most common behavioral disorder in children. 8 to 18% of children have ADHD worldwide. So it's fairly prevalent, but again, you really have to stick to those diagnostic criteria for ADHD, kind of gauging symptoms before 12, as we highlight here.
I want if possible, their school history, and did teachers identify a problem back then? And some of these
poor grades, poor performance.
Right. Did they suggest an evaluation to the parents, et cetera? Right? Did it look like there was a long history of this? Because some of the adult onset ones were, as is often the case, were actively using at the time the diagnosis was made. And so the substance use disorder or mood disorders or anxiety disorders, all that can lead to impaired focus and concentration. So sometimes we end up with people that are just using a chemical to be up and feel good, and then the next time they need a chemical to sleep, and then when they go to work, they need a chemical to be focused and complete their work.
Vicious cycle of sorts.
Yes, it's something that.
Yes, and there is evidence that treating ADHD actually can improve sobriety rates. There's a lot of debate still about how you treat. Stimulants are not widely accepted to treat someone who has a substance use disorder, but
I have seen a few people that if I was treating an outpatient population, I may consider them in the ADD was primary, it was severe enough, they'd never had an issue with amphetamine medications. But this talks about using delayed release preparations, monitoring prescription renewal times, a lot of close observation. As a triggering a priming of the reward pathway can really take them down the course of relapse to whatever substances they were having trouble.
It can be a risky decision. So really thoughtful approach, making certain you have a lot of management control over the prescriptions is important.
Yeah, we tend to use a lot of bupropion, atomoxetine, clonidine, guanfacine, steering away to treat the ADD symptoms.
So co-occurring PTSD and substance use disorder, this is something we see commonly here at Lakeview. We have a high rate of PTSD in both our male and female populations. Women, I would say, is a higher rate for certain. And if you look at epidemiology, it's estimated 40 to 90% of the population have been exposed to a traumatic event, but only about 10 to 20% will develop PTSD. So there's a lifetime incidence about 8.3% to develop PTSD. High rates in veterans, especially veterans who have PTSD. They're often the ones that are seeking treatment for substance use and vice versa. And what we see most commonly is PTSD will precede the substance use disorder diagnosis. And so that goes back to that self-medication hypothesis.
Yeah, this slide really talks about when and how to assess for PTSD and timing. Best after the intoxication or withdrawal period makes sense, and it indicates a scale that can be used. Most widely one being the clinician-administered PTSD scale for DSM-5. It's a 30-item structured interview. Again, an additional tool to use along with your history and observation in the program in response to therapies. At the bottom point talks about medications that can be helpful, kind of a broad spectrum there, and includes clonidine, prazosin, beta blockers. We use those sometimes symptomatically to decrease hyperarousal and nightmares.
And they can be very effective.
And they can be very helpful. And one key that's not actually mentioned on here, or one medication group is left out, and that's the
benzodiazepines, which actually show they can worsen PTSD symptoms rather than alleviate them. So thinking about co-occurring again, there really are no medicines that can block the development of PTSD. But as Dr. Holbert, you mentioned, they do help with that hyperarousal. And if you control some of that hyperarousal, there are very good therapies that we have in this slide specifically. Cognitive focusing therapies, cognitive processing therapies.
Which kind of combines the cognitive focus therapy with exposure-based therapy. Yeah.
And these are some first-line therapies. EMDR is one that we set a foundation for here at Lakeview for people to learn about eye movement desensitization and reprocessing therapy. So there's a lot of good evidence-based therapies out there.
Okay, personality disorders tend to develop in late adolescence or early adulthood when these personality patterns tend to become more set. Again, these are also correlated with substance use disorders, and the presence of personality disorders, not surprisingly, negatively affects the course of treatment of substance use disorder and can be associated with worse outcomes. So bottom point talks about some prevalence in the population in general, about 4 to 13%, a mean of 9.6%. You see the cluster C, kind of anxious spectrum disorders more commonly diagnosed in the general population. The cluster B disorders more commonly associated with substance use disorder, whether it's assessed in the community or treatment centers like ours, and particularly antisocial and borderline patterns.
Exactly. So we're going to pivot to special populations, and we do appreciate everybody's patience. I know we're going over a little bit. But special populations, I really believe we wanted to highlight a little bit the suicide and overdose deaths and polydrug use. We're also hit a little bit on COVID. This is actually an older article, but it estimated drug overdose around 72,000 in 2017.
Again, already talking about fentanyl, which is only increased by our clinical experience since that time.
It has, and here in Jacksonville, we've seen a spike of people using heroin or what they believe is heroin, and it turns out it's fentanyl, which is a very dangerous and has contributed to a high rate of deaths from overdoses.
And it's more difficult in the withdrawal period to determine when to use buprenorphine or initiate buprenorphine, for example. So you're initiating your detox protocol becomes a little more complex.
It does, with new analogs that are out there. So for this slide specifically, it really just highlights that top line there.
Rise in drug overdoses.
Just in general over the last decade or more. But you see that one line at the very right that kind of tracks up in an almost vertical, and that is just highlighting the increased risks with heroin and that higher rate of overdose with heroin.
That it's hooking up and matching the prescription and overtaking eventually the prescription drug overdose rate. All right, this slide. Up to between 2010 and 2014 changes substances related to drug deaths in the USA. And you can just see some trends there with fentanyl moving up, methamphetamine moving up, prescription or street oxycodone kind of moving down, and later times heroin, cocaine in the top two slots, and now we could probably say heroin slash fentanyl in the top slot, I would think.
Exactly. And these are numbers from 2014 and 2010. And if we look, for instance, in Massachusetts specifically, and I worked up there in that time period, we see that the main point of this busy slide is that fentanyl is going up. And again, it's that transition that people started to make from prescription drugs to heroin and then to fentanyl, and how fentanyl is very dangerous. And this, again, was just Massachusetts data. So another star,
here we go.
Demi Lovato.
Demi is here.
And she's been in the news very recently talking about brain injuries that she suffered from an overdose. And that's the overdose that we highlight here in July of 2018, where she ended up buying a drug, which she thought was oxycodone, and it actually turned out to be laced with fentanyl, which is, again, a much more potent opioid, and ended up overdosing, nearly died. And the more recent news has been that she believes she had suffered some brain damage during that period where she was unconscious and her breathing and respiratory centers had been turned off. So we highlight this person specifically because of the risks with what people think they're getting on the street and what they really get. The poly drug use that's mixed in here. It's evolving to be more of the rule rather than the exception.
The risk is one thing in people that haven't even developed a tolerance, but some of these folks already have a tolerance, and then they get something that they're not anticipating. It's much, much, much stronger, and it leads to an overdose situation. And Narcan was mentioned there at the end of that slide, and of course we keep that on hand here, and
in all the buildings.
We try to get everybody that's discharging to have some Narcan around. It's kind of like a defibrillator on the wall.
Exactly, and that's here at Lakeview we're doing community Narcan trainings and dispensing Narcan. I think it's, like you said, it should be everywhere, with a defibrillator on a plane, just everywhere where it can be accessed, because you can save a life that way.
Save a life, or at the least buy some time till EMS can get there and provide further care.
This next slide just is highlighting that there is a risk with suicide, alcohol, and overdose deaths, and that poly drug combination. Sometimes we have to look at it from a different lens. I believe that we're missing people that might appear to be overdoses when in actuality they're suicide attempts. A literature review from 2004 shows that substance use disorders and suicide, people with opiate use disorders actually have a 13 times greater risk for suicide than your general population, which is a tremendous increase. And a study with veterans shows that with an opiate use disorder and a comorbid psychiatric disorder, they have a risk for suicide in women. It actually is double what you would expect. So those are pretty high numbers.
This next slide just kind of illustrates where there's some greater concentration of age-adjusted overdose deaths in the state, kind of in the Northeast, Mid-Atlantic, Midwest, and then you see Florida showing up in Louisiana in the South, New Mexico as well.
Deaths of despair, I was referring to that a little bit earlier. These are people that have risks of depression, risks of poly drug use, alcohol. This is an increasing thing that we're seeing, this population, people that are dying from suicide and overdoses. And it changes state to state. So as you can see in West Virginia alone, alcohol and overdose deaths are up fourfold, and that's numbers that go to 2017. So I'm certain that those are much higher since COVID. And certain states are affected differently. So for instance, Wyoming and the Dakotas and Oregon, we are seeing high rates from alcohol and suicide rather than overdose deaths.
Yeah, you mentioned COVID, and we'll talk a little bit about that a little bit more later on. But I just hear recurrent stories now of people that were in a strong recovery program, maybe on their medications for mood disorder, et cetera, that they were isolated at home,
lost their job,
lost their job, their support group meetings
went all online,
and most of them just felt that wasn't quite as right for them.
Yeah.
And so many stories that their program kind of fell apart and then led to relapse and exacerbation of their co-occurring disorders. So I hear that a lot.
Heartbreaking.
Yeah. Oh, this slide, again, it separates deaths from suicide, alcohol, and drug overdose, and kind of the suicide and alcohol causes more in the west, northwest, and the plains area, and the drug overdoses kind of, again, in that mid-Atlantic and northeast areas.
Hit a little bit earlier on this, intentional suicide versus unintentional suicide.
It's worth investigating.
It is. And a lot of strategies that are out there right now don't account for the fact that someone who might have had an overdose was actually an intentional overdose. And it's really important to dig in and get those questions answered. Ask them again, ask them several times, because people change their answers. Often there's shame or embarrassment from something like that. And it's really important to get that data, because you might be missing an important mental health disorder or diagnosis.
I have a lot of people, Ellen mentioned something else on this slide, that have several that will tell me, no, I didn't have any intention, but I was of the state of mind that if I took this substance or blend a combination of substances, I didn't care about what happened to me. I would not care if I didn't wake up.
Exactly. Yeah. I hear that a lot.
I hear that a lot.
And they know the specifics of what they're taking. They know how much has gotten them high versus done other things. And so I think it's important to ask.
And at least in Jacksonville, we have Project Save Lives.
Yes. It's a great project.
It's a community project, kind of coordinated with over at Gateway, but in cooperating ERs for patients that present with an overdose situation. Once they're medically stabilized, they are assigned a peer that looks into that, further explores their situation, and can help them set up treatment for their substance use disorder and mental health. Yeah.
And it's a community or integrated community response project. So you have fire rescue, and you have physicians and Gateway, which is the community mental health and substance abuse program locally. So it's a really great program.
Data from fire rescue shows that overdose rates have dropped in Jacksonville since the initiation of the program.
Exactly. It's been a really good program. So we're highlighting another star. This is a very tragic story. It's Anthony Bourdain, who's a well-known food critic and has written a number of books, but he was also an open about his substance use and his mental health problems, a very successful person. Again, highlighting that people that have fame and fortune still are at risk to develop problems and maybe not even get the right treatment. And so he had been in recovery at the time of his death. His suicide was in 2018. And interestingly enough, when they did his autopsy, he did not have substances in his system, even though he was a former opiate use disorder and former drug user. And so that I believe highlights that post-recovery, when people are in sobriety and recovery, there's still that risk that they're dealing with a mental health issue, mental health symptoms, that post-recovery dysthymia or anhedonia that still needs to be treated. And you highlighted earlier that brain threshold for dopamine hasn't recovered.
Yeah, and I'm not sure, it would be interesting, I'm not sure if he was on, or what type of treatment, if any, he was receiving for his mood disorder at the time of his suicide. But I think it highlights those threshold changes, and probably he just never kind of felt back to normal or okay after he became sober.
We have Prince.
Another tragedy.
Favorites, yeah. This is very sad. And I think this talks about chronic pain complications. He developed a respiratory illness after he had been injured on stage, started on opiates, and then when he died, and this is believed to be an accidental overdose, he had been on high doses of opioids and had a respiratory illness. It was a contributory factor. Very sad.
Which if somebody had been there with Narcan, maybe something could have been done, maybe. Avicii is another suicide in 2018. He had a struggle with alcohol addiction, medical complications from alcoholism, and recurrent depression, and a lot of work stress and pressure there. And he actually committed suicide by cutting himself in a hotel room by himself with a wine bottle.
Really tragic.
Absolutely. And Little Peep, another one.
Yep.
Accidental overdose in 2017.
and rising hip hop star, had incorporated a lot of his drug use into his music, had struggled with depression and anxiety. He had polydrugs in his system, a combination of prescription and illicit drugs, cocaine, cannabis. So very
First,
tragic.
you look at that and you go, what was he thinking? But yeah, and that is an important thing. What was he thinking? If we were assessing this, if he had survived, or other people that have been in a similar situation, you can see just one of those substances could have led to this, let alone this combination.
That combination. And an accidental overdose is presumed, but again, we're not entirely sure with his mood history. So thinking about all of these things, it's important for us to identify treatment for co-occurring disorders. And as you can see here, we're going to hit on all of these. Again, know that we're a little short on time, so we appreciate everybody hanging in there with us. We're going to talk about exercise, ECT, EMS, co-occurring specialized therapies, and that biopsychosocial approach that is so effective. So just a little bit on exercise. There's a lot of really cool research coming out of the University of Buffalo, and a researcher up there showing that exercise can help people restore those good, healthy neurochemicals post-recovery, specifically dopamine, but also serotonin, norepinephrine. And the general recommendations are that people engage in exercise 3 times a week, at minimum 3 to 5 times, for 30 to 45 minutes, because the data shows that is where that recovery, that neuro recovery is starting.
Release those good feeling endorphins. Our patients typically can't wait to be off detox and go to the fitness center.
Exactly.
And it's always a benefit.
It is for sleep, for brain recovery. Eminem specifically highlighted here. He's actually got several years of recovery, beyond a decade, and he talks and is documented about his addiction. And one of the key things that he credits in his recovery is exercise. He actually got compulsive about exercise, but
lost about 81 pounds, I believe.
Yeah, that's a lot. But has actually become more balanced in his exercise approach, and is still a part of his recovery, and a very effective part. And I feel like, given 2021 and 2020 have been a very tough year for the world,
Absolutely.
It's very important for us to just highlight what COVID and its effect has been on mental health and substance abuse, or substance use disorder. So we hit a little bit on this earlier, but data that was just released from the CDC and National Institute of Drug Abuse shows that drug overdoses, just general drug overdoses, have increased by 30% from the end of 2019 through the end of 2020. And that's tremendous. So we had been winning the war, or making really good progress up until COVID hit. Another thing I feel is very important is to highlight that people that have substance abuse or substance use disorders and mental health disorders have higher risks of getting very sick if they're infected with COVID, and even mortality or death. And one of the reasons we encourage our patients and our staff to get the COVID vaccine, because it can be very protective for those severe issues. Suicide rates actually plateaued and went down a little bit in the early part of the pandemic. However, in the second and third waves, we've seen a higher risk in the minority populations, people of color. And then there's been generally an increase in anxiety and depression over the last year. From August through just February of this year, we've seen rates go to 41% of anxiety and depression. We know that,
like you just said, everybody has been affected.
Yes. The Johns Hopkins chief psychiatry estimates at least 20 to 30% of Americans could use mental health interventions. Children and adolescents and the elderly, the elderly being very isolated during COVID, children and adolescents losing those developmental milestones that come with school and social interactions. And again, high rates of hospitalizations and deaths related to COVID and those that are vulnerable.
And so we hope that all of this also illustrates that mental health professionals, psychiatrists are really needed in the addiction field, and historically, for some reason,
haven't been
as involved as maybe you and I have been.
We really feel compelled to be part of this field, but I know historically it's been hard to get psychiatrists to be involved. So we really believe that this is going to make a difference in treatment. and they can be real advocates for their patients.
We're going to mention this here shortly, but it's rewarding. Treatment does work. If you do the assessment, figure out what's going on, follow people, treatment does work. So it's rewarding.
For both sides.
Oh, yes. And Kitty Dukakis, a lot of people, if I mention ECT, they cringe, because of the
portrayal
of
movies and books and TV.
Yeah, I used to do a lot of ECT. It's safe and effective. Some psychiatrists I speak with these days say it's sometimes a bit of a hassle depending on the facility they're doing it in, coordinating with anesthesia and doing those things. But it's still safe and effective, particularly for refractory unipolar depression. It also helps in bipolar depression and even mania, and some in schizophrenia. So, and Kitty Dukakis experienced that benefit. She had a course of ECT and then has been on maintenance ECT with continued benefit for her depression, and she also had alcoholism. And she's written about it in a book, I think, called Shock.
Yes, still gets it to this day.
Yeah.
A fairly newer treatment for depression, major depressive disorder, is TMS, or transcranial magnetic stimulation repetitive. TMS has been very beneficial, FDA approved, and some evidence is showing there's evidence that it can help with people that have substance use disorders. And in fact, Dr. Luigi Galimberti in Italy has been very successful using TMS to prevent relapse. And again, that's an important name to keep in mind as we get towards the end of this presentation. The targets are that prefrontal cortex. There's really, really good evidence that is emerging that shows it may be beneficial for those with alcohol use disorders, nicotine use disorders, cocaine, opioids. So this is an emerging treatment that really shows some benefit.
It appears when they target the prefrontal cortex, it propagates into the midbrain area and kind of resets that circuitry.
Exactly. Kind of triggering also or targeting the emotional memories you were talking about earlier, the memories that are associated with cravings and use, those triggers. So there's some really exciting evidence happening there. And just, again, one of those emerging treatments.
Well, this slide highlights the biopsychosocial approach and aspect of treatment for these patients. Psychosocial therapy is a critical piece, but some examples here: a complete medical psychiatric evaluation, maybe infectious disease testing if it's indicated, depending on their exposure, and we're going to be applying the 12-step peer support therapy as well as individual therapy. So try again to treat the whole person.
Exactly. Very effective.
And this just highlights a few of the specialized therapies for some of the primary psychiatric disorders: CBT, exercise, DBT, for MDD, for major depressive disorder, meditation, social rhythm therapy, which really refers to making your day and night cycle routine, and reestablishing appropriate circadian rhythms. Right.
Exactly.
GAD, CBT, hypnosis, meditation, exercise. We try to employ these as much as we can here to help these folks.
And this highlights, too, some of the specialized therapies that are out there. Personality disorders, I think DBT, or dialectical behavioral therapy, can be very effective for that group, and it has applicability to the substance abuse population as well. Targeted pharmacotherapy can be used. We know PTSD, we've talked a little about those therapies, EMDR included in there as well. ADHD, metacognitive training, so helping people understand how they think and why they think what they do, and being more structured and organized with their thoughts.
And so why do we do any of this?
Great question. Hopefully you come away with good answers.
Yeah, so the assessment, figuring out what's going on, making an appropriate diagnosis allows you to apply the appropriate treatment, and treatment is important and effective, improves quality of life.
Reduces relapse risks.
Reduces relapse risk. reduces the significant symptoms of co-occurring disorders, and importantly, some of those slides we saw, reduces the risk of suicide.
Yeah. So we are very grateful, everybody. I hope stayed with us, and we will be releasing these slides if you weren't able to stay for the whole presentation. But we feel very passionate about this topic. It's an important piece of treating this special population. So thank you for joining us, and we hope you have a great day.
And good luck on the post-test.
Yes, good luck on the post-test.
Hope we did a good job.
Yeah.
Okay. Well, I think we have some questions we're going to look at.
So question number 1, what about limbic retraining programs?
I haven't applied neurofeedback, but I'm understanding that there is, there is some evidence of benefit there.
There is, yeah.
But I haven't applied it in this setting. I think it can be helpful in people kind of understanding their symptomatology, what triggers them, and learning ways to reestablish regulation in those areas of the brain.
System. Exactly.
Yeah.
Next question. Isn't PTSD also very prevalent on individuals raised in violent and negative environments, family and society together, who have little options to make positive choices and thus affect their levels of anger, anxiety, resentment, leading to self-medicate through substances?
I think absolutely yes.
Yes, without a doubt. And in fact, I would say, especially in our female population, we see a majority of them have a childhood trauma or even trauma that extends into relationships as an adult, where they're making poor decisions about partners, and that just escalates their mood, their anxiety, and then they self-medicate. It's a really tight cycle or vicious cycle. So absolutely agree with that. As a person who often works with EDs, or I'm guessing eating disorders.
Eating disorders, okay.
Yeah. I'm wondering, doesn't the dopamine system naturally reward eating?
Yes.
We know that, absolutely. Especially if binge eating is often correlated to a period of restriction. That is something
I don't know about the degree of change in that, but it definitely does binge eating. I have a patient right now that's dealing with those issues. As other stressors have come on, he's become sober here from his substance use, but now his eating disorder and binge eating has resurfaced as he's looking for that reward again.
And we see that, and again, thinking about our female population, we have very high occurrences of eating disorders. They get clean of alcohol, they go through detox, and then again, like you said, they're looking for that other reward. So I'd absolutely agree with that.
And it says, I would like to know if your people who actually have food addictions. I think all of our addiction personnel here would agree with that.
Absolutely. Yeah. It's not in the DSM yet, per se, food addiction, but we do know there's a strong association. Have you had experience, hold on, it's a little hard to read that, with the amount of young individuals reporting psychosis by THC? It seems the contents in THC are now different, from
absolutely.
The past.
Rachel mentioned that about how the concentration is higher.
Much higher of THC, which is your psychoactive ingredient.
Have absolutely seen lots of problems with spice K2, but also now with non-spice, with the higher concentration of THC in cannabis, seeing more associated psychosis, including a young 23-year-old that I had recently.
Yeah, and I think how we've, as a country, kind of medicalized marijuana and made it look to be the
More benign.
Yeah, more benign, a health product,
A treatment
cure-all.
option, a good treatment option.
I think that only spreads the idea that it's not harmful. And in populations, especially young adults, teenagers, with brain development still active, it can be very harmful, addictive and harmful.
And this even, it's an issue with general medical providers out there that are legitimizing this and writing these medical cards in Florida and other places.
Definitely. Okay. Whatever symptoms still present after the span of time are not triggered by addiction.
I'm not sure what they're meaning. Whatever symptoms still present after the span of time, not triggered by addiction. Well, I mean, if that is coming up, you're going to wonder if there's relapse going on, right. After a period of sobriety. You're going to wonder if you have identified appropriate co-occurring disorders and possibly they're not being effectively treated.
Right. I would agree with all that.
That's what
I'm going to take away from that.
Okay.
Yeah.
Okay.
How long would science consider appropriate for the brain to rewire itself and function appropriately regarding compulsivity, rationality, effectively ensuring that whatever symptoms are not triggered by the substances? And I've seen data that say upwards of 2 to 3 years even.
For complete recovery.
Yes. And that really also depends on the quality of recovery that someone's engaged in.
And we do the neurocognitive testing for our professionals.
Yes.
And at the minimum, we usually go out several months.
Yeah, 9 months or a year.
6, 9 months to retest. And then sometimes there's not adequate improvement and they have to continue on and retest later on, particularly with alcohol. Yeah. So this will depend on the substance used or the combination of substances used. Right. So it would be hard to give somebody an exact prediction, but it's a fallacy for these folks to believe that they're going to correct this in days or weeks.
Right. And when they leave us after 6 weeks, their recovery is just starting. So I think it's hard for people to kind of grasp.
I see gains in these things, compulsivity, rationality, things like that. I see gains made here while they're in treatment, but it's only going to improve with
a longer time period. I wonder if addiction triggers a dormant mental illness rather than causing a temporary one.
If addiction triggers a dormant mental illness rather than causing a temporary one, I think in more cases, if there's not already a primary co-occurring psychiatric disorder, I think it's more likely to be temporary, but this kind of goes to that question about somebody developing schizophrenia, where was it just part of their natural timeline, or did the use cause an earlier onset?
Coincidentally
or was it just coincidental?
Yeah, it's a hard question to answer, really. And I think, again, it gets to what you really encourage is assess, reassess, longitudinal history. I think all of that can be important. And sometimes it's very hard to define or determine.
Right. But I would say most of the time, a lot of the mental illness symptoms should get better if it's a primary substance use disorder induced.
Yes. Within that, even for psychosis, for instance, within that month
or so, it should
improve 15%.
Except for methamphetamine.
Except for methamphetamine. So.
Okay.
Scroll up. Okay. Is REBT as effective as DBT in the recovery population, or is one preferred over the other? I would have to say, I love DBT.
Yeah,
that is my go-to as far as what I recommend for patients. I think anything that's addressing those kind of behaviors and really helping people find some regulation to their mood and their impulsivity, it's going to be effective.
I think we do more of that than we do RBT.
I do too.
Yeah.
Okay. Great. Thank you.
All right.
Thank you, everybody.
Thank you, everyone.